Okay, good evening. On behalf of the College of Anesthesiologists and Intensivists of Sri Lanka, I warmly welcome you all to our monthly webinar for medical officers in anesthesia. I kindly encourage you to invite your anesthesia colleagues to join this webinar series. It has been organized for your benefit and will directly contribute to ensuring safe anesthesia for all Sri Lankans. Today, I'm pleased to introduce our moderator, Dr. Anuraja Abesundara, Senior Lecturer and Consultant Anesthetist at University Peradeniya and Teaching Hospital Peradeniya. He's a very active member of our college and will introduce our speaker today, Dr. Kavya Boteju, and moderate the sessions today. Dr. Abesundara, over to you to moderate the session. Thank you.
Thank you, Chamila. I think this is an important occasion, of course, to talk on some of the subjects. And on behalf of the college, of course, we need to welcome you all again because we have a huge number of people at the moment, doctors around us. Very happy to see you all. And today's topic is actually regarding the burns. Of course, if you talk talk about the burns, I mean, if you go to the history of burns, the recorded burn treatment has been there for centuries ago. I mean, they have treated with honey and resins for the treatment of burns before the birth of Christ even in 1600 BC, somewhere very long time back. And then, of course, now today also we have a classification of first degree, second degree, and third degree burns. Now this classification had been used by the German surgeons in the 18th century. So that is some times ago. And of course, we are using sulfadiazine today even. And it was actually first introduced in 1960, as I remember, right? So I think the burns has gone a real marvelous way, and because the incidence of burns are very high. So there's a progression of the burn treatment as well. Today, of course, they have reached some kind of a very enormous achievement, to the enormous achievements like now they are treating the burns for some kind of treatment like stem cell treatment as well, so to improve the outcome as well. Now, regarding the burn and anesthesia, of course, most of the times go in and hand, right? With the burn treatment, anesthetist and the anesthesia, the measures are vital from the beginning to the end, right? It's a kind of a long-term treatment. So today our speaker is Dr. Kavya Boteju. She is a consultant anesthetist and she's a senior lecturer of Jawaharlal University. And she is working in police hospital Narahempita as well as a consultant anesthetist. Now about her milestones, of course, she had her primary education and the secondary education in Galle and Colombo. She has gone to Vishaka Vidyalaya, and then of course her undergraduate career started at Sri Jawaharlal University, the same place where I stay here now. And she got through MBBS in 2010 and with the second upper merits. And then, of course, she completed her internship at NHSL in 2011 to 2012. And then, of course, she started her career as an anesthetist in 2014. And after that, by 2018, she got through the MD examination, part 2, and she has worked as a registrar and SR after that. Then, of course, she had her foreign training in Leeds NHS hospitals. She has worked in 2 hospitals. One is St. James, and the other one is Leeds General Infirmary. And that was during 2021 and 2023. To her merit, of course, she has authored some books and she has some publications as well. She has authored neuroanesthesia and neurointensive care. She is a co-author of that, of course, and then she has had written article on organ support in Journal of Sri Lanka College of Anaesthetic Journal. And of course, she was a contributor to NTMC Trauma Manual, Student Manual, Chapter 10. So and then of course, there are some publications as well. I think this is a good opportunity to get updated on burns, because burn, we can do a lot. Burns incidence is also high. So I think this is the right time to open your eyes and, to learn something more. Over to Dr. Kavya.
Thank you very much, Dr. Anura, for that very comprehensive and kind introduction. So without further ado, we will move on to the topic of the night. So we are going to talk about burns and anesthesia, and we'll discuss why it's a high-risk partnership for medical officers in anesthesia, why we are very much involved in managing burns, and how important it is to be updated and know what we need to do when we come across a patient. So we will focus on the early priorities, the airway strategies, how to resuscitate these patients, and the pitfalls we come across when we are managing them intraoperatively, and when we are handing them over, the concerns that we have to address. Right. So why is this a high-risk partnership? Like any other trauma, we can address their issues according to the airway, breathing, circulation, that algorithm. So when it comes to the burns airway, especially if they have inhalational injury, if they have burns to the face and neck and the upper airway, that becomes problematic to us. So it becomes a difficult airway. And there are some other concerns which we will discuss in detail, right? And the breathing also, if they have inhalational injury, that can affect the gas exchange, and oxygenation can be affected. So it's quite important. Then the circulation. You might remember that burns patients, they can go into shock. So they can be hypotensive and their intravascular volumes will be low. So we'll discuss in detail about how to pick these patients, how to resuscitate them, and the goals of resuscitation. We'll talk about all of that. And then comes our drugs. So in burn patients, actually the anesthetic drugs, their requirement changes as time goes by. Because in the first 48 hours, there will be certain physiological or pathological changes which take place, which will affect how the anesthetic drugs and some other drugs act as well. So it's very important. And also in the operating theater, if you have worked in relation to a burns unit, you might know that they are actually frequent visitors to the theater. They are recurring customers. So it's very important to be well versed with how to manage burn patients over time. So that is why we say burn injury, it turns patients into actually moving targets. Their physiology changes as time goes by. So so we have to know how long the time since burn injury, and we have to anticipate certain changes and complications so that we manage the patient well. So let's look at the learning objectives for tonight. So at the end of this session, hopefully you will be able to recognize burn patients who need advanced airway and early airway interventions, right? So which patients are actually difficult to manage and who will deteriorate in the coming minutes to hours. So it's important that we identify them and intervene early and understand what to do for their airways. And also, we will learn how to estimate the severity of a burn. So there are two things which we need to think about: the depth of the burn and also the total burn surface area, and also the presence or absence of inhalational injury. That's very important because having inhalational injury, that's going to put our patients at risk. So we have to know how to identify them if they have inhalational injury. And also the resuscitation part. how to resuscitate them, what kind of fluid to use, how much fluid to use, and when to stop resuscitating as well. So our end goals of management, that is also quite important. And then we will discuss about the anesthetic management, how we can plan induction, ventilation, and the other important aspects of anesthetic management, especially in these patients, about temperature control, about blood loss, analgesia, and also IV access. And also, at the end, we will learn how to avoid the classic errors that, because sometimes we don't realize that their physiology is very special. So we might commit some errors. So today we will understand how to how to not fall into this trap of errors. So first I'd like to open with a case just to open your thinking. Right, so let's think there is a 35-year-old man who was involved in a house fire and he's brought to your hospital 2 hours afterwards. And when you assess the patient, he has 28% of the body surface area involved in burn. So 28% total burn surface area. And the depth, of course, it's mixed depth. Some of it is deep, some of it is maybe partial. And we'll talk about how to assess the depth in the coming slides, right? And also there is involvement in the face, neck, chest, and both arms. There are vital areas which are involved in these patients' burns. And when you examine, you see that his voice is hoarse, and he also has singed or burnt nasal hairs, and there is soot in the mouth. And this patient has a respiratory rate of 30, saturation of 99% with the non-rebreather mask. So that is with high flow oxygen. And he has a tachycardia of 132 and his blood pressure is 96 by 58 millimeters mercury. And he's in severe pain. He's very anxious. And you realize now both his arms are burnt, that peripheral IV access is difficult. So what are the thoughts coming to your mind? Anyone from the audience would like to answer? Yeah. So in a patient like this, what are your concerns? Without taking too much time, I'd like to hear your opinion.
Avia, this is a house burn, isn't it? Inside the
Yes.
house. Isn't it?
Yes,
Yeah.
inside the house.
For 2 hours, he was waiting in the house, isn't it? So,
Yes, he was trapped in the house for 2 hours. Yeah. So your priority. So let's look at what really comes to our mind in a patient like this, right? So airway becomes a major priority, right? Now, because there's obvious injury to the face and neck, and also his voice is hoarse, and there are singed nasal hairs, there's soot in the mouth. So all of these clues tell you that he's probably having upper airway injury and maybe inhalational injury as well. And then the next thing you would think about is how to assess how much fluid this patient needs. Now, he's actually in shock. He's having a tachycardia and his blood pressure is marginal. So then how much fluid to give, that is something that we need to think about, right? And the IV access. Now, both arms are burnt. So maybe you'll have to go for a foot cannula or maybe even a femline or a neckline if there is some skin left over. So you have to think. These are all the things that you need to think about. And what kind of induction agents you can use in this patient, and also what are the complications which are now brewing, which you have to anticipate in the coming hours, right? So this is like a framework of things that we have to think about when we approach a patient like this. Okay, so with that in mind, let's go to the burn physiology. Just an overview about burn physiology. What we have to understand is that their physiology keeps changing hour by hour. So your patient will change in front of your eyes. So we have to understand what will happen in them. In the first 24 hours itself, the burn shock sets in. There will be capillary leakage. There will be edema because of the leakage. So there will be edema in the airways as well, which will make the airway more difficult. And then they can go into shock due to the reduction in cardiac output. As time goes by, like 24 to 48 hours, the edema will peak and the shock features will also start peaking. And if they have had inhalational injury, this is the time where you get the peak effects as well. And in the days to come, they will go into a hyperdynamic state, and the drugs, of course, there will be increased clearance. And these patients might need repeated procedures. They might need wound debridements, hysterectomies, all of that. So that is what we have to anticipate in the days to come. On weeks to month, again, they are in a catabolic phase where they are catabolizing their fats and proteins. So their immunity is low, and they can develop various infections. And also, this is the time that the contractures will set in, and they might also develop chronic pain syndromes if we haven't addressed the pain properly in the initial stages. So this is like the basic timeline of a burn patient. So this is what we have to keep in mind. Right. So let's look at now assessing the severity of burns. So one thing we have to address is the depth of the burn. So just to refresh your memory about the skin anatomy. So there are three main layers, as you remember. There is the epidermis, the dermis, and the subcutaneous tissue, right? And the epidermis is the most superficial layer, and the dermis is subdivided into further layers. You have the papillary layer, the reticular layer, where you get all the blood vessels. So the burn depth is classified according to how much of this epidermis and dermis is involved. So if we look at assessing the severity of burns and the depth involved, right? So burns are classically classified as first degree, second degree, and third degree, or even fourth degree burns. So first degree burns are the superficial burns, which involves only the epidermis. So the patients might present with just a red patch of skin. So here they're very painful because the free nerve endings are exposed. But these kind of burns, they don't blister and they heal without scarring. So they're very superficial. And actually, we don't include these superficial first degree burns to the total burn surface area as well, because they heal without scarring. They don't blister. So they're not actually used into factored into the calculation of total burn surface area. Then we have the second degree burns, right, which involve the dermis. Again, second degree also, they are subdivided into two categories: the superficial partial thickness burns and the deep partial thickness burns. So both of these categories, what we have to remember is they blister, and there may be fluid coming out of these blisters, or weeping, we call it. And so the problem with them is that they, of course, heal with scarring. And with increasing depth, of course, the risk of infection goes up. And they will be very painful because, again, some of the nerve fibers, nerve endings will be exposed. And most of them, the deeper they go, will need surgery, debridement, and they will form scars when they heal. The deeper the burn, the less painful, because most of the entire nerve fiber is burnt off. They won't have that much pain, but the more superficial burns will be more painful. And then we have the full thickness or the third degree burn, where the entire dermis is involved. They are very dry and they won't be sensitive. So to light touch, even they won't be able to feel light touch and pinprick sensations. They will not be able to feel. Small areas, of course, they might heal with substantial scarring, but most of if it's bigger, the full thickness burns, they will require skin grafting. And of course, the risk of infection is very high in this type of burn. Then there's another degree, fourth degree, where the tissue is burnt up to the bone. So it involves muscle and bone. So these are very severe burns. Here, of course, they will end up with amputation if they survive such a severe burn. Okay, so that's how we classify the burn depth. It's important because second and third degree burns will be factored into your total burn surface area, whereas the superficial first degree burns will not, we don't calculate that into the burn surface area.
Abhi, one question actually, in a superficial burns, of course, we don't calculate the fluid evenness. Is that correct?
Yes, yes, yes,
So you
yes.
don't have to
So
worry about the fluid loss in the very superficial burns, isn't it?
yes, yes. Even if it's a larger area, if it's a very superficial one, they don't usually go into shock. So we don't have to resuscitate them the way that we resuscitate the major burns. So one of the things is the deep and so the partial thickness, second degree and third degree burns. So then we'll come to calculating the total burn surface area. This is very important because this is what we use for fluid calculation. So patients who have 15 to 20% of their total body surface area involved in the burn, in second or third degree burns, they usually go into shock. So we have to resuscitate them extensively. So we have to know how much fluid we need to give. So this is a very important thing to know, how to calculate this total burn surface area. One of the most simpler ways of calculating this is the rule of nines. So it's like there are 9 nines. We divide the body into 9 parts, and each of them will be 9% of the body. So 9 times 9 is 99%, and then the remaining 1% is the genitalia. So this is for an adult. So basically, lower limbs, they will take 2 9s, and the upper limbs 1 9, and the front 1 9. Then the back will take another 9. So that's how all the 9, and the head also another 9. That's how the 9 9s come into place. And in children, of course, they have larger heads and torsos. So this demarcation changes. So this is a diagram showing how much the children's burn surface area is calculated. Infants, of course, it goes further up their head, and the torso is even more, take even more of their total body surface area. So the most accurate way of calculating this is using a Landau chart. And if you get a patient with modern technology, you can always draw this up in your phone or tablet and calculate the patient's burn surface area accurately. And another easy way of remembering is the patient's palm with the finger. That's 1% of body surface area. So you absolutely don't have access to these charts. You can use that method as well. So what's important is that we need to calculate the total burn surface area in second and third involving second and third degree burns. So it's important to know when we need to call specialist help, either your surgical unit, or if you have a plastic surgical unit, you can refer to them. So if it's a partial thickness burn of more than 10% body surface area, then that warrants a referral. And any full thickness burn again warrants a referral, right? Burns to face, hands, feet, perineum, and major joints, all of this will also might need surgery. Of course, plastic and reconstructive teams will be able to recover them very well. So it's important that we refer them early. And of course, inhalational injury patients might need ICU ventilation, so you have to refer them early. Then chemical and electrical burns, there are special types of burns, so it's important that you refer to a specialist unit. And also, even not such a complicated burn, but if they have severe comorbidities or associated trauma, again, the surgeons and, of course, the anesthetists and the ICU physicians might need to see them. Right. So that is how we assess the severity of the burn. And then, of course, with all of this, now we know that deeper burns are more severe, and total surface area of 20% or more is severe. And the other thing which makes burn injury severe is the involvement of inhalational injury and airway injury. So now let's move on to that section. I have involved some quite graphic images, but I included them to show you the gravity of airway and inhalational injury. So, and it's very important for us because even if they're not going into surgery, they might call us for intubation. So it's important that we know how to assess a burn patient's airway and also what to do if they are involved, right?
Kavya, you said that one of the histories actually regarding the inside house burn, isn't it, earlier? And
Yes,
then, of course, if somebody gets a burn patient, that history is really important, isn't it?
of
To
course.
initially suspect the inhalational injury, right?
Yes, for sure. Even there, if there are no external features, the history itself, we have to keep a high level of suspicion and act quickly if that's the case. So let's look at some of the clinical clues to inhalational injury. Um, There are some features in the history and the scene of the injury, which will tell you that maybe this patient is having an inhalation injury. So, like Dr. Anura said, like fire in an enclosed space, like in a house fire, of course, there is a very high risk of inhalational injury in them. Because they will be trapped for hours and they'll be inhaling carbon monoxide and other toxic gases. So it's very important to know that in the history. And if it was an explosion, or if it was a fire involving heavy smoke, if it was burning some kind of chemicals or even material. So recently, I'll tell you about my personal experience where there was a burn in a textile shop in PETA. So in that, there was so much smoke generated. So and the patient, of course, did have inhalational injury. So that's quite a good clue as well. And if the patient was unconscious, most likely because he inhaled some toxic gases, maybe carbon monoxide, he got hypoxic. So that also will give you a clue about inhalational injury. And steam burns, if there was a lot of steam generation, again, airway injury is quite likely. These are the features in the history of the scene that we have to elicit, we have to keep in mind when we are approaching such a patient. Then let's look at the examination clues. If the patient has, so you can see this diagram on the left. This is the typical patient who will be having airway and inhalational injury. Their hairs will be singed, they will be burnt. Hair in the head and even nasal hairs, all of that could be singed. And there will be soot and black particles in the mouth, and their sputum will be black. They can be having stridor, hoarse voice, and there might be obvious burns on the face and the mouth and the neck. And there will be swelling in the on the face and the neck. And also, if it's very severe, they may have difficulty in breathing, and their work of breathing will be high. So these are the features typical um, of a typical patient with airway and inhalational injury. So another thing to keep in mind is when you monitor their saturation, when you put the saturation probe on the finger, it might be normal. Because if the patient has carbon monoxide poisoning, the pulse oximeters that we have at hand, most of them can't differentiate between carboxyhemoglobin and oxyhemoglobin. So the pulse oximeter will read carboxyhemoglobin as oxygenated hemoglobin as well. So the saturation reading might be misleading in these patients. So you have to look at the clinical picture, how they are, if they, the likelihood according to the history, and how unwell they are. These things you have to keep in mind when you are assessing a patient. Right? Okay. So, so we need to incubate most these patients early, patients with airway injury, and we'll look into why we need to incubate them early. So what kind of features will tell us that we need to rush and quickly incubate them before their airway becomes more difficult. So let's look at some of the features. If they have deep face and neck burns with obvious swelling, of course, we don't have much time to waste. We have to act quickly and incubate electively. And if they have progressive edema, if they have stridor, which is developing or worsening, or airway obstruction, again, that's an indication to act quickly. If their consciousness is reduced, and if the GCS is low and if they can't protect their airway, again, that's an indication to intubate them early. And if they're desaturating, if their gas exchange is worsening, or if their work of breathing is increasing and they are becoming tired, they are going into fatigue, then of course, again, you will have to intubate and ventilate them early. And even without any of these features, if you need to transfer the patient for a procedure or to a specialized unit, and if we anticipate that this patient's airway might worsen and you can't observe them, right? So that's an indication to intubate them early. And if they need bronchoscopy, again, you need to intubate them as well, right? Okay, so sometimes if they have just isolated only external stoot with no other features, you might be able to observe them in a high dependency unit, right? If they don't have stridor, if they don't have any other worrying symptoms, you might be able to get away with not intubating them, but you have to observe them quite closely in a high dependency unit. So that's what we have to keep in mind. But of course, we have to have a low threshold for intubating them early before the airway becomes more difficult. Right? Okay, let's talk a little bit about poisoning. So, smoke also contains all of these poisonous substances, which can cause detrimental clinical pictures. So, carbon monoxide is one of them. I told you earlier that the pulse oximetry can mislead, especially in fires involving enclosed spaces, right? So, there is only partial burning of oxygen. So it might not be able to reduce to carbon dioxide per se, the burning substances. So you will have carbon monoxide forming because there is not enough oxygen for carbon dioxide to form. So then there will be carbon monoxide accumulating in these enclosed spaces, right? So you have to really think about carbon monoxide poisoning in these kind of enclosed space burns. And if you have a high level of suspicion, then don't wait. I would say give them 100% oxygen. Have a low threshold for giving them 100% oxygen. And then you have to look at the other symptoms, like neurologic symptoms. They will be acidotic. They might have ECG changes. All of these things will show you that the patient has carbon monoxide poisoning. And of course, if you can check, if you have 4 oximeters, you can check the carbon monoxide carboxyhemoglobin levels as well. Another thing is cyanide gas inhalation, especially if there were chemicals and plastics involved in this burn. Hydrogen cyanide might have been formed. So the patient can have cyanide poisoning and they will have severe lactic acidosis and they can coexist with carbon monoxide poisoning as well. And the treatment is hydroxycobalamin. So a practical takeaway about all this is just because the patient has a normal saturation level, you can't rule out inhalational injury or poisonous gas inhalation. So you have to treat first, then investigate in parallel. If you have the slightest doubt, please give them 100% oxygen because that will buy you some time. Okay.
Kavya, now you said
yeah.
about the inhalation. One thing, of course, you said about the edema. That's the with the time, of course, you don't have to intubate at once, isn't it? We can wait. You said like that. And the other one is if you have this kind of a history in the burn patient, of course, we need to always better to give from the beginning oxygen, isn't it?
Yes, of course. So we have to give 100% oxygen for most of our burn patients, unless if it's like a, let's say, hot water burn involving deep skin or something like that, where the airway might be intact. But most of the time, open flame burns, they will come with hypoxia. So oxygen is definitely a priority in these kind of patients. So before we move on to the next part of the presentation, I'd like to share one of my personal experiences actually. 3 years ago, almost 3 years ago, there was a fire in PETA, you might remember, in one of the textile shops. And so there were 6 patients who were critically ill. All of them were brought to NHSL, and one of them ended up in my ICU at the neurotrauma unit. So I thought it would be an interesting case to share with you. So it was a young boy, 20-year-old male, ASA1. He came to the ETU, and at the ETU, he had some particulate material in the throat, and he was gasping for breath. Saturation was 88%. He was tachycardic. Blood pressure was actually high, probably due to the sympathetic overdrive at that time. He didn't have any external burns, so it was purely airway and inhalational injury in this patient. His GCS was 4, was low, and his pupils were okay. So we gave him 15 liters of oxygen via non-rebreather ambu. Saturation picked up. We cannulated, gave a fluid bolus, and the important thing is that intubation was done with a rapid sequence induction, and managed to get a 7.5 millimeter tube because we intubated him early, and also DEXA and antibiotics were given. So after that, this patient came to my ICU, and at the ICU, we ventilated him with these parameters, and he had widespread bilateral bronchi. Saturation with 0.6 FiO2 was 100, PaO2 was 136, but he was still hypoxic. So one of the key points in inhalational injury is to do bronchoscopy for the patients. So within a few hours of admission, I did a bronchoscopy on this patient, and this is a short video clip of the bronchoscopy. You can see that the airway is quite black, and I did a bronchial lavage. And that much of black sooty particles were in his airways. So, and these are some of the still photographs of that bronchoscopy. And this is my sucker bottle. So I actually lavaged out this black material from the patient's airway. So yeah, so that's how much smoke and black particles, carbon particles, which can end up in a patient's airway, especially in a fire like that, which generated a lot of smoke and where the patient was trapped. So afterwards, we implemented lung protective ventilation. We allowed permissive hypercapnia. He was a little acidotic, but we allowed that. And actually, on the next day, we extubated him and he was discharged a few days afterwards. So a second bronchoscopy was also done on this ICU day 2. And that also, we managed to take out some more black particles. And I think this material can mount immune reactions and scarring and problems later on if bronchoscopy is not done at this stage. So that was my experience managing such a patient. And that is the severity of inhalational injury.
Kavya, you, I think, highlighted a very important points up to now, I think. Regarding the inhalational burns, it is not the airway alone, isn't it? There are other measures, isn't it? One is probably oxygen, 100% oxygen, if depending on the type, the inhalation injury. And the other thing is early bronchoscopy, and then, of course, bronchial lavage. That might help a lot, isn't it? So, I think when somebody gets an inhalational injury, we need to think all of this rather than intubating, isn't it, alone?
Yes, for sure. Yeah. So keeping that in mind, I thought it would be interesting to present an airway plan for a patient like this so that we have some kind of blueprint of what to do when we come across a patient like this. So first thing is, if it's airway and inhalation injury, we have to anticipate the difficult airway. Especially if they look like this patient, if they have a facial burns, soot in the mouth and the nose, singed nasal hairs, and if their voice is hoarse, if they're having stridor, we have to assume that they are going to have a difficult airway, right? So in that case, we have to prepare as we are going to intubate a patient with a difficult airway. So all the adjuncts, we need to prepare everything that we have at hand. Video laryngoscopy if we have, UG, stillets, and of course, we have to be ready with smaller endotracheal tubes, maybe 6 millimeter, maybe even smaller if it's a smaller person. But be ready with smaller size tubes because of the airway edema, and of course, suctioning devices. And if we have high flow oxygen devices which can deliver apneic oxygen during the apneic phase, we should definitely get that involved in these kind of patients. It will buy us time for our interventions. And of course, supraglottic airways. And if everything fails, we should be ready with front of neck access as well. So we should have everything at hand so that we don't have to panic if we fail with our plan A. Right. So plan A, of course, is intubation, intubating early, electively, before the patient's airway deteriorates, before the edema worsens, right? So we can use all the adjunct that we have. If you are familiar with using the video laryngoscope, by all means, please use it. And if you have a video laryngoscope in your hospital, please use it in non-emergency cases, so you all are familiar with it. Gentle technique, of course, because their airway tissue will be very friable, and if we try maybe 3 to 4 times, it might damage the airway further and the edema might worsen. So maybe 2 attempts and then you can move on to plan B. Again, these are not hard rules. Depending on the patient's airway, we will have to make the decision, right? So as with any intubation, you have to confirm placement with our capnogram. So make sure you attach your capnography as well. And then plan B will be, of course, supraglottic devices and two-hand ventilation. So plan B will be to make sure that the patient is oxygenated, even if you don't get the tube in, right? So we can use a supraglottic airway device, first or second generation LMA. If you have intubating LMAs, maybe we can use that, and we might be able to guide the tube through that. And of course, two-hand ventilation might be useful in a situation like this, where you can oxygenate the patient. So if oxygenation also fails in this kind of situation, then we will have to go for front of neck access. Then we have to declare can't intubate, can't oxygenate, and we will have to go for a front of neck access. What's recommended by the Difficult Airway Society is the scalpel bougie tube technique. So we can use that. Right. So this is just a blueprint so that we know that we have everything at hand ready for a difficult airway. And we have our backup plans sorted so that the patient doesn't die of hypoxia. So that we have a plan of oxygenating this patient. So that is the main thing I wanted to highlight about airway. Dr. Anura, anything you want to add to this?
Yeah, I think this the quite correctly. I think you said, and the timing is really important, isn't it? For instance, now you don't have to intubate at once these kind of patients, but should be alarmed and then should be very vigilant of the timing, isn't it? Now, if it is too late, of course, we may not be able to intubate. There are instances, of course, your glottis will be very, very narrow, so even a size 3-4 tube may not be inserted, isn't it? So
Yes,
timing
yes.
is really an important factor with regard to this inhalation injury, isn't it?
Yes. So early intubation, if they are having airway and airway injury and inhalational injury, you might not see the symptoms initially when they present, but depending on the history and the other features involved, we have to electively intubate them before their airway becomes problematic. So I think that is the take home from this airway section that we have to remember, that we can't wait until they become bad. We can become bad within hours. So if the history and the other examination features are suggestive, we shouldn't wait, but intubate these patients. Isn't it, Dr. Anura?
Yeah, that's
Yeah.
I think these are the messages that we need to keep it in mind. And
So now let's move on to another important aspect of patient management, burn patient management. Another thing is that they require quite a lot of fluids. So that's what our experience tells us, that usually even patients who come to the ward, they will need a lot of fluids.
yeah,
But
this
it's
is
yeah.
quite a controversial factor, isn't it? Fluid replacement, where
Yes.
there had been a lot of changes in the recent past as well about the fluid replacement. And you might go through this probably, isn't it? Right?
Yes, yes. So the important thing is that we give them enough fluids to perfuse the tissues, but we shouldn't be drowning them in fluids. So that is the important thing to remember. Traditionally, what was taught to us in medical school and all, that is that we have to give so much fluids, and we use the classic Parkland formula. But there are some changes to that, and we will discuss that in the coming slide. So before we move on to the management, let's look at what burn shock actually looks like. So after the initial burn injury, there is a lot of inflammatory mediators which are released from the body. So these cause a massive capillary leak. So the capillaries, they become highly permeable. So there will be plasma leaking into the leaking out of the capillaries. So when the plasma leaks out of the capillary, one thing is that there will be edema. There will be edema in the surrounding tissue, including the airway. And the other thing is, now inside the vessel, the fluid will be concentrated. So there is intravascular dehydration. So because of this, the venous return to the heart will be reduced, and that can cause a shock in the patient. So there will be hemodynamic shock. Their blood pressures will be low. In response, they can have a tachycardia. So all these things can lead to shock in these patients. So what we do in the initial resuscitation phase is try and counteract this fluid leakage so that the venous return is restored and the blood pressure is restored. So our goal is actually to maintain tissue perfusion. We have to make sure that the vital organs are perfused. Vital organs like the brain, heart, kidneys, lungs, we have to make sure that they are perfused. So that is the aim of our treatment. So they do require aggressive fluid resuscitation, but we have to be careful about some targets. So there are some targets that we expect in these patients. We'll talk about it a bit. So first, let's look at what kind of patients, what kind of burn victims actually need fluid resuscitation. So adults with burns of 20% or more of their total body surface area will require fluid resuscitation because they most of the time go into shock. For children, of course, this percentage will be lower because they are more prone to going into shock and going into dehydration because their body surface area is higher in comparison to their body weight. So children, of course, the threshold for resuscitation will be lower. So here, the other important thing I mentioned earlier, you have to count the partial thickness and the full thickness burns only. The superficial burns are not counted into this. So you might remember from medical school days that we used to use this Parkland formula where 4 milliliters per kg of the percentage burn surface area was used, and out of that also, that is the requirement in the first 24 hours. Out of that, 50% was given in the first 8 hours, and 50% in the next 16 hours. However, what was noticed with this kind of management is that some of the patients were over-resuscitated, and there were some complications which arose by giving such a huge volume of fluid. So there were things like pulmonary edema, abdominal compartment syndrome, right? So all of these things happened with giving such a big volume of fluids. So now the current practice is actually to use a starting point of 2 ml per kg and then go up or down according to the patient's physiological parameters. So we resuscitate these patients with some endpoints in mind. We start at 2 ml per kg of the percentage total burn surface area. And we use a balanced crystalloid to resuscitate them, balanced crystalloid like Winger's lactate. But what we have to remember is that this is just a starting point. So depending on the patient's parameters, we might have to increase this fluid requirement or even come down. So, the thinking is that the actual fluid which we need to give the patient is what the patient actually needs. So now let's look at what kind of endpoints what we need to think of when we look at resuscitating these patients. So one thing we have to monitor is the urine output. If they are in burn shock and if we are giving large volumes of fluid, of course we need to monitor their urine output, right? And their mean arterial pressure, ideally with an arterial line, but even with the NIBP multi-monitor in HD or ICU setting, if they are hypotensive, it's required to monitor their mean arterial pressures. And of course, heart rate. So MAP of 65 or more, and if they are hypertensives, you might need higher pressures. And we try to keep the heart rate below 120. And also they have to be, if they are losing their consciousness, that will indicate that now they might be in severe shock. And also the lactate levels can be monitored. lactate levels and the base deficit. So serial blood gases should ideally be done. So an outline, of course, will be quite useful in a patient like this. You can, so while you're targeting these endpoints, you can look for complications such as hypotension, tachycardia, low urine output. So if they are present, you might need more fluids for these patients. And also the other end is that you can monitor them for abdominal compartment syndrome. So some cavities maybe can monitor the bladder pressures if it's really indicated. And also you can, of course, auscultate them and see if there are threats developing. That's what we usually do in the ICUs to see, we always auscultate. So the minute they're developing even fine threats, then you would be concerned about the fluid status. And of course, IVC volumes and other cardiac output monitoring if we have the facilities to monitor them. So just another slide about what really changed, why we moved from this 4 ml per kg traditional volume towards 2 ml per kg. So what they found was that there were more complications such as pulmonary edema, compartment syndrome, and so on. So yeah, like I said earlier, you can use the 2 ml per kg as a baseline and go up and down according to that, depending on the depending on the patient status, right?
One factor is, of course, the age as well, isn't it?
Yes, yes.
Particularly in old age, we have to be a little bit careful about the fast fluid resuscitation. Otherwise, there will be problems, isn't it?
Yes, yes, of course. You have to be very careful, like rather when you're resuscitating a 40-year-old, 30-year-old person and as of to an 80-year-old person. So you have to keep all these things in mind, and especially if they have comorbidities, again, we will have to be very careful. So again, to reiterate the endpoints or the goals in our fluid management, urine output of 0.5 to 1 ml per kg per hour for an adult, mean arterial pressure of 65 meters mercury or more. And then the lactates, of course, maybe 0.4. We can aim for something like 0.4 or less, or maybe a little higher depending on the patient's parameters. Then, of course, the base deficit, whether it's improving or not. And then the peripheral capillary refills and the peripheral perfusion as well. So what we have to keep in mind is that we have to avoid large boluses unless they are really hypotensive. And we should not ignore rising edema, tense, the abdomen becoming tense, or even lung threats. So, and the other thing is sometimes with over sedation, you might not notice these things happening. So, or even the under resuscitation, you might not notice with over sedation. So, that's important that we keep that in mind when we assess the patients.
So your endpoints will be one is urine output, as you said, and then
Yes.
blood pressure, obviously, and you're particular about the lactate. Why is that?
So developing lactate indicates that there is increased anaerobic metabolism in the periphery. So that means that we are not perfusing your tissues enough.
Yeah,
So
that
with
means
the
adequacy of the perfusion, isn't it?
yes. So that will be one thing whether the patient so when the perfusion is restored, that will also be reversed and the lactates will start coming down. So that is why that is also an important term. Right. So another thing is that in addition to monitoring, IV access, of course, will be difficult, but ideally, 2 large bow IVs, if possible, we should get it. Maybe using ultrasound guidance. You can cannulate deeper veins using an ultrasound early in spares, in areas where the skin is spared. And if they're really crashing, maybe you might have to go for intraosseous or a cut down. And maybe central access if the resuscitation is going to be prolonged. And if they need vasopressors, you might have to go for a central line early as well. So things that you monitor, I mentioned them earlier, but just to tell them all together. A catheter is a must, especially in higher degree burns. and an art line if available and if it's really indicated. Of course, the temperature monitoring is very important in these patients because they can lose heat quite a bit from their body surface area, especially because the skin's protection mechanisms are lost. And also monitoring the compartments, whether the abdomen is becoming tense, and also the lymph perfusion. All these things are very important. So other thing I actually wanted to mention was when we intubate the patients, we have to make sure that the tubes are secured quite well because even if we intubate early and if the edema sets in later on, the tube ties and all can get buried in the patient. And of course, we should never cut these tubes. Sometimes we cut the tubes after intubation, but these are not patients where the tubes should be cut. So uncut endotracheal tube secured properly, and the same goes for your IV lines and central lines as well. So it will be difficult to anchor these tubes, but you have to make sure they are nicely secured because there's a high risk of tubes dislodging and it will be difficult to get them back in. Yeah. So this is the basic burn management. Dr. Anura, is there anything you would like to add before we go on to anesthetic management?
Yeah, I think you highlighted about this the compartments, isn't it? That is one thing that
Yes.
we need to keep in mind in your first previous slide, probably compartment syndrome, and then of course there could be compartments in limbs, so that you need to release as soon as possible, actually. So, but it may not occur within the first few 1 or 2 days. Sometimes it can happen if you overfluid, isn't it?
Yes. Yeah. Later on with contractures and all
Mm.
that, so that can develop. So that's something you have to keep in mind. So now let's move on to the anesthetic management of these patients. That's very important because they will need recurrent surgeries. If the burns are severe, they will need recurrent surgeries. So depending on the time since the initial injury, our management might have to change as well because the drug requirement and the type of drugs we can use, all of that will change. So, of course, we highlighted about airway management. We have to keep all that in mind, especially if a patient is coming for the first time after a short period after the burn injury. You might have to intubate them for surgery in theater. So then you have to think about all the difficult airway things that we discussed earlier. Have a plan ABC, have all the equipment ready, and go for your intubation. So tube fixation, uncut tube length, ready with smaller tubes, all that you have to keep in mind. Then, of course, the resuscitation. You will have to resuscitate them to a certain degree before we induce, if you can, ideally resuscitate them and get them before surgery, right? And of course, you have to have blood ready because with these burn debridements, you can lose a lot of blood without you even realizing because there are so many open capillaries where the patient can lose blood from. So you have to have blood ready, cross-matched and ready for these patients. And you have to monitor the urine output, lactates, and the body temperature, as I mentioned earlier. So it could be a debridement, it could be a grafting, can be an eschorotomy, can be a whole spectrum of surgeries that these patients need. So you have to assume the expected blood loss can be calculated, and according to that, you will have to have blood and fluids ready, right? And of course, the positioning is very important. Sometimes these patients might need bone positioning, lateral positioning, right? And to make sure that their joints and skin it's secured, that you have silicone pads if available and properly secure them, and also have warming devices. That's a must for these patients because they are very prone to hypothermia. Right. So if we think about induction in these patients, um, if they are unstable, if they're not well resuscitated, then if you have to go for the induction, of course, we have to pre-oxygenate them aggressively and have that difficult airway plan in mind and have skilled assistance, right? And we can use an induction agent, which usually preserves blood pressure. Something like ketamine, if there are no other contraindications, that's actually quite useful especially because they have the analgesic effect as well. So ketamine is a very good drug for these kind of patients, especially if they're hypotensive. And even if you use other drugs, you might have to use a cocktail of drugs so that they don't go into hypertension. So might need a bit of maybe ketamine, midazolam, and maybe adding a little bit of propofol. So like that, you might have to really tailor your anesthetic drugs if they are hypotensive, right? So that's what we have to keep in mind. Like most trauma patients, and especially these patients, because they are in burn shock, we have to keep in mind that their blood pressures can drop faster if we use traditional doses of our induction agents. So you have to tailor the agent and also the doses as well. And the other thing is, if they're undergoing repeated surgeries, the other thing we have to keep in mind is that neuromuscular blockers. So SUCs are important thing to know. It's acceptable to use it in the first 48 hours. But what happens after the first 24 to 48 hours is that there are extra junctional receptors which form. So there are acetylcholine receptors which form elsewhere out of the neuromuscular junction. So then when you give succinylcholine, what happens is they will act on these extrajunctional receptors as well, and that can release large amounts of potassium and cause severe hyperkalemia and can cause arrhythmias. So you have to be very careful not to give succinylcholine after the first 24 to 48 hours, right? And then as so and then later on they can develop resistance to neuromuscular block. This is blockers. So most of the time this is true for drugs like rocuronium, but even atracurium, you might notice that effect wears off quite rapidly. So the key principles to highlight, you should give a balanced anesthetic. A useful adjunct will be something like ketamine, and try to use opioid sparing and analgesic principles, like you can use IV paracetamol, NSAIDs, and alpha-2 agonists in some selected settings, right? And the other thing to remember is that these procedures are very stimulating. Even a simple wound toilet can be very stimulating. So you have to keep in mind that they might need a big dose of analgesics. And with repeated anesthetics, they can develop tolerance to opioids. So that is also something you have to address. And but their pain should be addressed from the beginning so that they don't develop chronic pain syndromes. Right. Heat loss is something we spoke about. So we have to make sure that only the really necessary part is exposed, and the theater is warmed enough, and that we use warming blankets. And then blood loss is something we need to anticipate. So uh, then we have to have bloods and things ready for these patients. And if they have a coagulopathy, that should be corrected. We have to prevent hypokalemia and hypothermia as well. So sometimes they might be hypocalcemic, which can trigger and worsen the coagulopathies. Right. Again, ventilation, ideally lung protective strategies, especially if they have lower airway injuries. And you can watch the peak pressures and the compliances as well. If they are very prone to bronchospasms, especially if they have inhalational injury, and secretions might be common. So you have to address those issues. And if they have circumferential chest burns, that might impede the ventilation. So sometimes they might need espirotomies and things like that. Yeah, so other thing is positioning. So if they have had skin grafts, you have to be very careful when we position them in the ICUs, HDUs, even in the theaters if they come for different procedures. And I mentioned earlier about lines being dislodged, so they have to be well secured. Right. Other special types of burns, electrical burns. So that is another special type of burn we have to be very mindful about, because even though the external burn wound might be quite minor, they might have severe deep injuries. They can have things like rhabdomyolysis, because there might be concealed muscle injury. So we have to monitor their ECGs, potassium, and of course the urine output, and you might have to monitor them for, especially if it's involving a limb, compartment syndrome. And in chemical burns, ongoing tissue damage might be happening. So after a acid or whatever burn, tissue damage might be ongoing until the area is decontaminated. So if you know the agent, that will help in the management as well. And in children, so the age-adjusted body surface area calculation should be used. And again, airway might be more difficult because the airways can narrow with edema very quickly. So again, you might have to act quickly. And heat loss problems, again, I said might be fine. And older and frail adults, of course, they have lower physiological reserve, so be careful when we resuscitate them. So then about the post-op management. So it will be ideal for them to be managed in a specialized burn unit where infections are very well controlled. So that will be ideal. But even if not, if they're managed in HPU, you have to make sure that you have to be very mindful of these patients getting infections. And again, the IRV status, if you're extubating them, you have to be very, to take a very calculated decision because reintubation will be difficult in them. So input, output, monitoring that, urine output, and monitoring the lactates, all that is very important. And blood loss and monitoring the hemoglobins and transfusing them as necessary. And of course, we have to have a very good analgesia plan for them. So sublingual ketamine, that is something which is a good option as an adjunct to the other agents, so that we won't be giving them too much opioids. And then lines and dressings and grafts, they have to be properly properly secured. So what kind of patients require HDU or ICU care? So if we are concerned about their airway, they should be monitored in a HDU or ICU setting. And if they are not completed their resuscitation and if they are hypotensive, again, ideally they should be in a HDU or ICU setting. And large burns and major physiological with a major physiological stress on the body, again, ideally HDU, ITU. Of course, ventilation or high oxygen requirement will require a high level of care. And if they are significant, if they have other comorbidities, again, they should ideally go to a HDU or an ICU. So this is basically the main points in anesthetic management patients. And now let's before we go to a few cases, let's just talk about some of the mistakes that we can make. Right. So sometimes you might miss inhalational injury if their saturation is normal. So that is something to keep in mind. And early intubation is something we have to really remember and stress and not wait until it actually becomes difficult. So bore-directed fluid therapy, use 2 ml per kg per body surface area, burn surface area as a starting point, and then we wait until the end points. And hypothermia is something we have to remember. And again, another drastic mistake will be using sucks days after a major burn, which can cause detrimental hypokalemia and even a cardiac arrest. So, and you have to keep in mind that the patients will need higher doses of muscle relaxants as time goes by. Right. Dr. Anur, anything you want to emphasize?
Yeah, there was a question actually from the audience. Actually, the one was asking about how to fix the tube if the full face is burned. It's difficult sometimes, isn't it? You can't paste something. It's a little bit tricky question actually. Very difficult to answer even, isn't it?
Maybe tying it and using some kind of securing dressing to tie it around, but that also will be difficult because with the edema. So we'll have to really use the common sense and use the available material in a time like that. Of course, in other countries, you have those professional ties, which I don't think it is available here. Like, the tube can be elevated and fixed.
Yeah, the ties like things may help probably, isn't it? Yeah, I mean, then and there you need to use your, as she said, the common sense. And you said, I think we need to highlight again probably use of suxamethonium. In the early period, probably you can use it, isn't it? Right?
Yeah,
Because
yeah,
you know this, it's not a dangerous thing in the first 24 hours probably, and then of
yeah,
course next few days is it's going to be dangerous. And little later, of course, after several days and you know the once the healing occurs, then of course there won't be a issue. And I have another question actually. This of course burn is a Kavya, I think it's a long term. You need the long term care, isn't it? I mean, active burns might be there for many days and sometimes weeks. And then, of course, after that also there are things that we need to do. The problem is actually use of antibiotics. Now, it's a huge problem because if you use unnecessarily antibiotics from the beginning, then of course we will end up in multiple resistances, and then of course we won't be able to use our normal antibiotics. I think we have to have some kind of understanding on how to use antibiotics, whether we need to use early or Kavya, when do we need antibiotics? At the beginning or little, I mean, do you need antibiotics at the beginning?
Not at depends on the like if it's a very deep burn, maybe as a prophylaxis, we might have to discuss with the microbiologist again and use what's best for them. But we should not abuse antibiotics as well,
That's
depending on
right.
the risk profile and
Yeah.
everything. And of course, using cultures to tailor your antibiotics and using all that, being a good antibiotic, using the antibiotic stewardship principles in these patients, that will
Mm.
be quite good for these patients. Again, I guess we'll have to tailor the management to each and every patient, if it depending on the
Yeah.
risk factors.
But generally acceptance is actually if it is uncomplicated like thing,
Mhm.
little bit you know reasonable burning, and then of course you don't have to use antibiotic from the beginning, isn't it? Right?
If
I
you
mean, if
keep
it
it
is
clean, isn't it? Yeah.
definitely
Yeah.
because we need to be careful, and if it is complicated, and then of course a lot of contaminations from the beginning, of course we may have to use. Otherwise, better as a policy generally we need to consider the antibiotics very carefully because unnecessary problems later. So that initially we don't have to, if it is a you know the normal burn, so don't have to use antibiotics at the beginning, probably, isn't it?
Yes, yes, yes. If it's a clean wound, and
Yeah.
I think we should be able to manage without antibiotics. Yeah. Uh, Right. So then we'll discuss a few cases in brief before we wrap up. So again, the same patient we discussed earlier, 35-year-old male, 28% body surface area burnt, and he has facial and upper airway burns. So let's just come back to the patient. So ideally, we should get senior help. We might need surgical, anesthetic, all of those teams involved in this kind of patient. And of course, high flow oxygen. We should be giving them high flow oxygen, and then prepare him for early controlled intubation. And IV access, if we can't get an IV line in the upper limbs, maybe in the feet or a fem line or whatever is possible, we should get good IV access early in these patients. Then start resuscitating, get the catheter, monitor the urine output, and we can use that to titrate our fluid volumes. And if they're hypotensive, we can get an art line in and use that as well. And in the first 24 to 48 hours, it will be accepted to use succinylcholine if we are going for a rapid sequence. Um, yeah. So second scenario, we'll quickly go through this patient as well. 22-year-old male with a 35% burn surface area, lame burns, returns, and now he's coming back after 3 weeks for grafting. So he's still tachycardic, warm, eating poorly, on regular opioids, and previous record notes rocuronium, slow onset. So now this patient is still in his hyperdynamic state where he's tachycardic and he's warm and he's in a catabolic phase. He's not eating properly, so he's probably losing a lot of proteins. He's prone to infections, and he's on regular opioids because of the pain. And now, because of these extrajunctional receptors, his muscle relaxant requirement has gone up. So with atracurium also, you will note a similar picture, but maybe not as much as rocuronium. So you have to expect higher analgesic needs in this patient, and might need higher doses of muscle relaxants, and you have to protect them from heat loss and blood loss as well. We have to prepare for blood loss also. So let's just look at simple simple framework. So airway, we have to see whether the airway is okay at the moment, whether it's going to deteriorate in the next 30 minutes to few hours, right? So if you think it's going to deteriorate, don't hesitate. Please go ahead and electively intubate them. And is there inhalational injury, carbon monoxide poisoning, cyanide poisoning, bronchospasms, if the chest wall movements restricted? In that case, again, you'll have to intubate, give oxygen, intubate, and ventilate them as well with lung protective strategies. And then circulation-wise, if it's a large burn, we have to assess when the burn happened and how long since the burn injury, and whether the resuscitation parameters are adequate. So we can see whether the patient is adequately resuscitated or not. And which drugs then, again, you have to think about the timeline, whether you need to give, whether you can give SACs to this patient, whether you can't, and what drugs to use for induction and also pain relief. And then we have to think about hypothermia, blood loss, and then post-op management, ideally in a specialized burn unit where the infections are controlled, or an HVO or ICU setting. So these are the key take-home messages. Burn patients are high risk for the anesthetist because all these, their physiology is altered, airway, hemodynamics, drug response, all of them have evolved with time. And airway is a big concern because airway can worsen with time. So intubate early if you suspect injury. And when you are resuscitating, use the burn formulae as a guide and go up and down according to that, targeting certain goals. So goal-directed fluid therapy using these burn formula as a guide. Then after 48 hours, avoid SAPs, and later you might need higher doses of Atra or Opironia. In the theaters, anticipate heat loss, blood loss, and IV access might be difficult. So all of these things you have to keep in mind. So that comes to the end of our presentation. Anything, Dr. Anwar, anything you want to add?
Kavi, actually, there are interesting questions from the audience, actually. If I read you,
Yeah.
one thing, is it worth ventilate through a tracheostomy for burn patient?
If the upper airway is not, if you can't intubate, is it?
No, I mean, generally what they say is that because we are talking about the, the tube and then of course installation of the tube and the taping the tubes and various things, probably they might, but initially we don't have to, but anyway, if it needs long-term care, probably we may have to go for a tracheostomy, for after maybe 10, 15 days, you may have to go for tracheostomy, but initially, unless the patient, if we can intubate, of course, we need to intubate, probably, isn't it, Kavya?
Yeah. Because at that point, we probably won't be able to say whether the patient needs long-term
That's
ventilation
right.
or not.
Yeah.
So,
There's another interesting and very difficult question, of course. Monitoring difficulty, especially ECG. Do we need a spare burn areas when we insert lines and various problems? I mean, these are very challenging problems, and I think very. What do you say?
So, I mean, again, you have to use like tailor it to each and every patient, isn't it? So if you can't get the ECG leads in the front, maybe you'll have to go to the back and or the abdomen even. So, or a limb, or like we'll have to, however we can get the a rhythm on the screen, isn't it?
Sometimes very extensive burns, of course, we may not be able to.
Yeah. Then you'll have to go by the other clinical parameters, of course.
So there's another question regarding the monitoring. Actually, I think, as we said, there are huge monitoring difficulties. Yeah, those are the actually questions. And somebody has several people have thanked you as well for your presentation. Yes, there's another question. Uh, yeah, is there a significant total body surface area to have a succinylcholine associated hyperkalemia? Is there
I don't think so. I mean, I didn't really come across that. But of course,
yeah.
if it's a minor burn, the risk will be lower.
Mm,
But generally, what they say is any burn, any significant burn after 24 to 48 hours, you get the extrajunctional receptors.
mm.
Yeah,
Interesting
I will.
question, isn't it?
Yes, very
Right.
interesting. It's
Mm.
worth actually reading a bit on that.
Yeah, we didn't
And
think about that even.
yeah,
Very nice.
yeah.
Actually, there's no hard and fast rules on this one. Of course, significant burns can, of course, can have hyperkalemia, but some other the moderate burns also you can have, isn't it? And many people have thanked you, as I said earlier. And yeah, now when to consider tracheostomy in a patient with severe inhalational injury? Kavya, what do
So
you
I
think?
guess if the airway is involved and if you think that going intubating from above is going to be difficult invariably, and if the patient is stable and if you have the surgeons available, going for an elective tracheostomy might be okay. So you have to
Mm,
really weigh the pros and the cons, isn't it? So if you think you're going to get into trouble by trying to intubate from the top, might as well go for an elective trache if that looks better if the neck skin is spared, isn't it?
mm.
Uh,
Uh, and then if there's another question, if patient having difficulty airway after 48 hours of burns, what is the muscle relaxant agent? I think you said basically
yeah,
that was not succinylcholine, obviously, right?
yeah.
Yeah.
So,
So
I
those are.
mean,
Mm,
we can use rocuronium, but the problem in our country, of course, we don't have Sugammadex, we're a little hesitant to use rocuronium, thinking if we get
yeah.
into trap of not being able to intubate. But yeah, rocuronium is can be used. That's a non-depolarizing agent that we use in other countries. But yeah, and then there is a technique of using atracurium as well, isn't it? Using the
Mm.
1/10 of the dose prior to giving your anesthetic agent and then giving the full dose and quickly intubate. So these are the options available to us.
Pre-attic urination, like,
Yeah,
yeah.
yeah,
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 that's
yeah.
right. So there are options actually. And only thing is, I mean, we need to assess the burn patient, get the history. I mean, this is not a kind of
Emergency situation, I mean, after 48 hours, most of the time, they will be faster, isn't it? Very unlikely that we'll have to, I mean, go for a real rapid sequence,
mm,
real emergency. So,
yeah. I think we learn a lot probably. I think you were able to describe most of the things very clearly.
I
And
also learned a lot while preparing this presentation, and
mm,
I enjoyed doing this presentation for y'all. And thank you, Dr. Anura. It was very interactive and quite useful, and it was nice having you moderate
yeah,
this session. Thank
I
you.
need, we need to thank the audience as well for interesting, very interesting questions as
Yes,
well.
quite a receptive audience. Thank
Yeah,
you. Yeah,
really happy. I think they also got some good messages. I mean, some very interesting points.
yeah.
Okay, thank you very much, Kavya, for your
Thank,
interesting
thank you.
presentation. Over
Thank
to
you, Dr.
Chandra.
Anura. Thank you,
Yeah.
Madam Shamila and the college. Thank you and good night.
Thank you, Kavya, for your very informative and very interesting presentation.